Good afternoon, everyone. Thank you so much for joining us. Hope everybody had a good lunch break. Hello again to all those joining us virtually. Hope you had a nice break as well. If you're here for Mythbusters, you're in the right room. So maybe I'll start. Laura, do you mind going first here? We've got 2 hand mics and 2 standing on the table.
Thank you. My name is Laura Tomolini. I'm the clinical nurse coordinator for CTAF, which is Group 4 PH, or blood clots in the lungs, and I work at the Toronto General Hospital.
Hi, my name is Kelly Kerwin. I work in the Vancouver Clinic. I'm a RN coordinator there.
You could probably use this one. I'm Mitesh Thakkar. I'm a respirology physician in both pulmonary hypertension and lung transplant in Calgary.
And I'm Gail Nicholson, and I am the clinical nurse coordinator for the Calgary program with this guy.
I'm David Langleben. I'm a cardiologist. I work in Montreal.
I'm Carolyn Doyle Cox. I'm the nursing coordinator in Ottawa, and I have the pleasure of working with Dr. Lisa Melnichuk, who's on the board, as well as Dr. Chandy, Contreras, and Duncan Stewart.
Thank you. Anybody want to start us off with a question? All right, we've got one down front here. Hi, Joanne.
Hi.
Wait for the mic. There we go.
I can use my teacher voice. Hi, I'm just wondering, I know we're at this conference and it's wonderful, and for me this is a new experience because for the past 3 years I've been very, very scared of COVID, masking up everywhere, and this September I'm starting back teaching in person, and I'm just wondering, what are your thoughts on COVID? Should a PH person still be masking up? Is it kind of, are we safe? Are we done? And I heard, and this might not be true, but I'm just wondering, did COVID cause PH in some people, or will it aggravate PH if you get it? So I'm just wondering that, and would love to have some facts about that. Thank you.
I can start, I suppose. I think COVID is still a real illness, and the reality is when you have pulmonary hypertension, any illness can be a destabilizing event, and so recognizing that we have to learn how to live with COVID, I think one of the keys, of course, is making sure you're fully vaccinated as much as your province will allow. Avoiding patients or people that are clearly ill is a sensible thing to do. Sanitizing. Masks are certainly effective barriers against transmission. There's obviously it's a very politicized intervention that people have very strong opinions about. I think in a tolerant society we should allow people who want to mask up not to feel that that's no longer needed. If they feel comfortable, they should. That would be kind of my advice on that perspective. In terms of does COVID cause pulmonary hypertension, I don't think we've seen any data to say that that's the case. Now, indirectly, there might be some downstream effects. We know that COVID can cause pulmonary emboli, and there's always been the worry of, are we going to see an avalanche of patients develop CTAF as a result of their pulmonary emboli? And we just saw some data yesterday at our think tank that suggests perhaps that incidence isn't any higher than we'd think. So, I don't know, Dr. Langleben, if you have any other comments.
Yeah, I agree with everything. I don't think, it certainly doesn't cause PAH. There are some people who've gotten very ill with COVID, and it's, basically tried to wipe out their lungs. And so they come out with a situation of lung scarring or sometimes inability to transfer oxygen well, and they need to be on chronic oxygen. And sometimes because the COVID virus actually attaches into the blood vessels in the lung, it can trash those blood vessels, the little blood vessels, and prevent oxygen exchange. So indirectly, some of those people will have high blood pressure in their lungs because they're missing oxygen or because there was a lot of scarring. It's nothing like PAH. It's nothing it might fall into what we call group 3, okay? It's not usual, it's not common as far as we know, but it can occur. It can occur. And as far as masks, I mean, our hospital still has a mask policy when there's patient contact. My Montreal people will tell you here I'm paranoid about it there. We really do insist that everybody wear masks, because imagine a waiting room. You never know who you're sitting next to. Some people are a little more conscientious or reflective on the fact that they can transmit COVID to other people and vice versa. And so the model I've always thought about is Japan, because 30 years ago when I was on the Japan subway with one of my Japanese colleagues, and there were people on the train wearing masks, and I said to him, why are they wearing masks? And he said, they have a cold. In Japan, it's common courtesy when you have a cold, you put on a mask. No one stigmatizes you. They know you have a cold, and in fact, it's a sign that you're taking care of everyone else in society. So somehow we have this mental barrier, against wearing masks when we have a cough. I think maybe thinking about it the other way is if you have a cough, do a good deed and put a mask on for 3-4 days. And that might help prevent all the spread.
Thank you. Another question? Thanks, Joan. Yeah, Jane? Thanks.
Hi, Jane Cernosky, patient here. I have idiopathic pulmonary arterial hypertension, so a big name for an unknown reason why I have a lung condition. One of some of my colleagues and I are just wondering about mold or things like asbestos and its role in lung conditions like IPH. Wonder if you could speak to that.
Sure. I mean, so we know asbestos causes a number of lung diseases, and it's on our fellowship exam, it's a classic exam question we ask all our fellows as they try to graduate. So we know there's a list of things that asbestos can cause, and again, pulmonary hypertension, or PAH specifically, is not on that list. Again, in a roundabout way, asbestos lung disease can cause scarring, which can cause group 3 pulmonary hypertension, but we wouldn't associate that with PAH. There's a lot of very interesting work going on about the inflammatory effects of the microbiome, which is all the organisms that live inside of us, whether that's in the gut or in the lungs, and what that inflammatory milieu might do in terms of causing PAH. We haven't identified a specific organism or organisms that do that, but there's some really interesting work going on about that. So in relation to things like molds and other microbiology, that story is still unraveling as we learn about this condition.
Thank you. Ian.
Ian Gibson, caregiver/parent. There we go. Some time ago, there was a Sapphire trial involving stem cells sort of emanating out of Ottawa. And COVID sort of complicated things in terms of getting people in to process the blood and whatnot. And we didn't really get to critical mass in terms of the number of people we wanted to study. And I think the people that were funding it sort of yanked the funding. However, there was certainly one person in our support group that showed great promise as a result of being involved in this. Do you see the potential for rejuvenating this stem cell approach to treating the disease?
I think, I mean, I can't speak as a researcher or a doctor, but certainly because of COVID, a lot of studies, all over the world just, stopped bringing people into hospitals. They wouldn't allow that type of visit. So unfortunately, I think it ran out of funding at the end and patients. So, I don't know if Dr. George Chandy, who was the lead, the primary in the study, I don't know they're not sure if we're going to pick up and do this again or not. I'm not sure if the other doctors have any idea, but it did, from my personal opinion, anybody that I saw go through this trial, you know, did appear to me to be doing pretty well. So we were really hopeful that we could get more. It was also very strict criteria to get into the study, so that's always very hard. You know, so people that walk too far, for instance, you know, they just, you know, we need to know at the end of a study, were you able to walk a little bit further? If you're already walking very far, then we would never know. So, you know, maybe if we do have this study, if it is something that we do again, you know, to look at the criteria, to look at, you know, things that we might be able to change, because I certainly think that there is a lot of benefit to your own body's cells helping you, you know, because we know all these drugs come with side effects, so that really would be brilliant.
Yeah, it certainly wasn't ill will in any way. I think it was COVID. We were a participating center and could no longer participate because, you know, there are easier studies and harder studies, okay? You know, providing pills to a center and the center gives the pills is what we consider an easy study. This required cell processing, cell sampling, everything. And it wasn't that that's so difficult. It's quite standardized, and really credit to Dr. Stewart. He really got it down very smooth. And the problem for us was that we did not have a cell processing center in Montreal that could do it. So much as I wanted, and I mean, I've collaborated with Duncan for over 35 years. We work very closely together. It really saddened me to have to say to him, look, I didn't want to lie to him. I just said, I don't think we're going to be able to do this right now. We don't have a cell processing center. And, you know, we couldn't ship our patients to Ottawa and vice versa. It wasn't going to work. And so the study stopped not because of any negative reasons related to the study. There were no catastrophes, there were no serious adverse events or anything like that. It was logistics. And then COVID hit and affected all the other centers. And, you know, companies being companies, especially American companies, they want, you know, results next quarter. No one sort of looks to the longer term, unfortunately. I hope this will revive. You know, as was said, the concept, first of all, because stem cells have the ability to regenerate things. The concept of administering stem cells, the concept of modifying the stem cells to produce beneficial agents. They're all really good concepts. And so I hope this, I doubt very much this strategy will be abandoned, but it will be returned to.
Thank you. Thanks.
Bonjour, c'est une question. Vous avez deux centres de recherche ici en avant. Vous avez l'hôpital juif, puis à Calgary, vous avez un centre de recherche. Je voulais savoir qu'est-ce que vous pensez de l'apabétalone, la recherche sur l'apabétalone. Apabétalone. C'est un...
Laura, should I speak in French or English?
English is fine, it'll translate.
You're asking the wrong people. You should be asking Dr. Provencher's group. I'll tell you what I think about it, okay? We're discovering more and more, the more we understand about cell biology, that there are very fundamental mechanisms and pathways to injury and to repair, okay? And certain pathways get activated or suppressed or stimulated and lead to injury. And then sometimes even the same pathway or other pathways lead to repair. In PAH, it's very obvious that we have multiple pathways leading to injury. And we also have deficits or problems in multiple pathways that might lead to repair. Apabetalol is touching one of the fundamental pathways. The good news is that, to my knowledge, it's been used in other illness, so we sort of know what it does in humans. And because of that, it is an agent that we can then translate into the PAH field. much more easily than if we had no idea what it did to humans. So the group in Quebec at Laval showed that this pathway is very important, showed that they have a medication to try it, and when a clinical research project is set up, it's much like a steeplechase. You're running, and then you have to jump. You're running, then you have to jump. You're running, then you have to jump. Each of those things, each of those jumps is the government, the company, the medication, recruiting the patients, watching for safety, watching for results, getting all the tests right, and to arrive at the end at a successful clinical trial is a very long race, okay? And so he's, as far as I know, he started to jump a few of them, and each one takes time. There's running between the next one. COVID didn't help. And so I think that he's about to come near another jump, okay? We are all very interested in it. We all want to, if possible, find patients to contribute to the trial. And I think it's very promising. Right now, we don't know if it's going to work. It's called apabetalol. That's the chemical name. I don't know what the brand name is.
Thank you. And just going back to the Sapphire trial, if anyone had any questions from a patient's perspective, Joanne Maidwood is here, and she was one of the patients in that trial. So hope you don't mind if I point you out, Joanne. And those on virtually online, if you have any questions, feel free to type those into the chat box, and we'll try to cover those for you.
Is there a cutoff age for lung transplant? And if there is, what is it?
So there isn't a formal cutoff age. Every program, you know, has built their own experience of transplanting patients as they get older, and so each program may set a cutoff age that might be different from a different program. By and large, you know, if you read the textbooks 10 years ago, they would say 65 was a hard stop. Now most programs will, you know, depending on the patient and other features of their medical history, will potentially offer transplants into the early 70s. You know, most programs that I'm aware of probably wouldn't offer transplantation in the late 70s. And it's a very nuanced and individualized discussion with patients about the risks and benefits of transplant at that age. So there isn't a hard cutoff, but somewhere around that.
We have an online question from Jolene, who is asking, what is the role of cardiopulmonary exercise testing in the diagnosis and/or management of PH?
That's a great question, and something that we're all really excited about. You know, cardiopulmonary exercise testing is for those that aren't aware, is a test where you take an individual and you put them on a bicycle, generally a stationary bicycle, and have them slowly progress how much work that they're pushing against with the bicycle. So you increase the resistance. And you can make measures of oxygen consumption and carbon dioxide exhalation and get a really good sense of why somebody might stop exercising. Is it the pulmonary vasculature that's limiting them? Is it their muscles? Is it their lungs in some other fashion? Maybe it's COPD, et cetera. So it's a very, very useful tool. I think we're still trying to learn how to use it in the best way. I was just talking to Laura, and she can sort of comment a little bit. Certainly in group 4 pulmonary hypertension, we think about CPET a lot as part of our standard workup. In the PAH population, I think it has a huge role in patients who, as was said earlier, are perhaps walking too far, or they're doing too well on a 6-minute walk test that you can't pick up subtle changes. And so CPET has another role there. Has to be done carefully in those that get sicker, just because there are some risks with the test, but it is a very, very useful tool for us.
I will add on to that as well, as he mentioned. So group 4 pH with blood clots in the lungs that eventually scar and remain permanent. So in CTAF in Toronto, if there are two options that we offer in this group. So we have a surgery, an endarterectomy, where we scrape out the scarring of the lungs, and essentially in many cases can reverse pulmonary hypertension. So this is a curable surgical procedure for pH. But more and more what we're finding is that the microvascular levels, so people that have disease further out in the lungs that are short of breath and it affects their life quite significantly, is too far for surgeons to actually reach these individuals, and they might actually have a normal echocardiogram or heart catheterization that do not show pulmonary hypertension, yet we cannot describe why they continue to have the shortness of breath. And it becomes more challenging because we are currently the only center in the country that is offering this alternative to the surgery, which is the balloon procedure. It's a vascular procedure, a lot less invasive. You don't have to have a sternotomy with your chest open. And so prior to this, we are still trying to diagnose and understand why these people are short of breath when they're having normal testing otherwise. And so this CPET is something that we're routinely doing a lot more, and then offering to these individuals that normally would have been declined surgery or this balloon stenting that can decrease pH and or correct it altogether.
Just want to make one comment, because we're a well-kept secret. Dr. Ali Abou Al-Saad, we have a very active BPA center. We've done several hundred BPAs, in Quebec and Montreal with excellent results. So there's, there's centers across Canada that are doing it now and with very good results.
And just one other comment. We had a patient with chronic thromboembolic disease. Dr. Melnichuk and I, met with her often. She definitely was very symptomatic, but normal testing, normal right heart catheterization, normal echocardiogram, and was an extreme, almost like an athlete prior to this. So very upset about her, deconditioning, inability to go up the flight of stairs, coughing up blood sometimes. And because of the CPET, she went to Toronto, and Dr. Duperreault actually decided basically on that test that did show that she would benefit from surgery. She had surgery, which otherwise, many years ago we would not have done, and she did beautifully, and she's been happy ever since. So it's really valuable. Yes, in your area, very valuable.
We have more online questions.
Great.
This one is from Duncan. For those patients who are on high doses of vasodilation meds, sometimes the general blood pressure can be too low. What precautions are advised for supplementing with salt tablets to maintain minimum this blood pressure without further harming the PAH and counteracting the benefit of vasodilator? How much daily salt is too much?
So I teach my medical residents, treat a patient, don't treat a number. My question back to that is, how is the person feeling? People, unless they're very, very tall, can tolerate borderline low blood pressures and feel okay as long as they're not getting dizzy or anything else. The benefits of the pH medications outweigh the number as long as they're feeling okay. Far outweigh the number. Obviously, someone comes in and they're getting lightheaded or what we call orthostatic, meaning when they change position, they get dizzy and their blood pressure falls. You then have to evaluate, okay, are they over-medicated? Is there some adjustment I can make in their pH meds which will not jeopardize their PAH and yet let them have a little more of a blood pressure? Or is there another reason? Is there a confounding illness? Are they lying flat most of the day so that they're like astronauts that are out of gravity, and then when they stand up, gravity acts and their pressure falls. Are they dehydrated? Simple stuff. Are they on too much of a diuretic? Are they on pills for blood pressure? There are many, many possibilities, okay? And so you have to look at each patient as an individual and individualize the treatment. It's very, very rare that we have to lower the blood pressure, the PAH medications to help with blood pressure. The endothelin antagonists really don't affect blood pressure. There's this evil rumor outside that phosphodiesterase inhibitors affect blood pressure, which goes back to the erectile dysfunction trials where people actually got some nitrates and it interfered with things. The PD5s generally are not systemic vasodilators except luckily for particular organs, okay? The prostanoids, the oral and IV prostanoids can affect your blood pressure because they're peripheral vasodilators. In addition, they're systemic vasodilators in addition to being pulmonary vasodilators. Riociguat definitely affects your blood pressure, but again, that's generally manageable. So you have to consider all the various factors, and then yes, sometimes you have to make an adjustment, but most of the time we're adjusting other stuff. And I don't recommend taking salt tabs, generally, for people with pulmonary hypertension, because the right heart may already be dilated and overloaded, and taking salt tabs will just pull more fluid into the body and you'll swell more, but it's not going to push more flow through the lungs into this underfilled left side of the heart. So that's usually not a solution. In fact, it's usually detrimental.
This doesn't replace, of course, treating the individual, which is a wise thing to do, but just I work in the Vancouver clinic, and our guidelines that we tell people, not with an established problem, but just normally we tell people that salt, you should stay under 2,000 milligrams a day, which is 2 grams. If you want a number, just to start looking somewhere. And for fluid, we usually say staying under 2 liters a day.
I'm just going to echo for the Calgary program as well. I agree with Vancouver. But we also notice that a lot of our patients, especially if they're on triple therapy, they can tolerate a significantly low blood pressure. I have many patients that their systolic pressure runs between 70 and 80 systolic, and they're fine. And that's what our case management model is all about, is the nurses call and do assessments, and the key is symptoms. So if they become symptomatic, then we're going to do exactly like Dr. Langleben says. We're going to look at the other drugs that they're on. Are they dehydrated? But the big thing is that lots of our patients can tolerate very low blood pressures, and they're perfectly fine with it.
Thank you for that question. Do you want to see if there's anything in the room first? Anybody else
sure.
in the room?
Hi, I'm wondering, with patients living longer, are you noticing that there's other problems coming up, like specifically skeletal muscle issues? I've read about that, and I've also experienced it. And I'm wondering if that is becoming more common and you're seeing that.
Yeah, I mean, there's a whole area of research looking at frailty in chronic disease management, and pulmonary hypertension is no different. And so frailty in medical terms, we think about as a function of muscle strength, muscle volume, and just the general ability to keep moving, right? And so this is a huge area of research in the pulmonary hypertension world about how can we continue to have patients keep moving and remain and keep that strength that they have. And so, you know, there's lots of discussions about pulmonary rehabilitation programs for pulmonary hypertension, et cetera. And so a huge area of research at the moment, but certainly a trend that we have noticed is that it is easy to lose that muscle mass and to lose that strength. And so it's a conscious effort to continue to hold on to that as the illness continues.
I also have another comment, and maybe you might be able to elaborate on it. Living longer, we have a few patients in our clinic that Dr. Melnichuk takes care of that have a history of connective tissue disease. And what I've seen over many years is some of them that develop like a diastolic dysfunction, like almost like a HFpEF, right? Their left side of the heart becomes a bit stiff due to that disease, and therefore the pressures on the left side of the heart can go up. So now someone may have pulmonary arterial hypertension and a bit of pulmonary venous, and that complicates treating them further with, other therapies. I don't know if you want to elaborate on that.
Yeah, I have to say, when I started, what we used to pray for our patients was time. Okay, and tragically in the beginning, no one could grant them more time. It's a new world now. It's not a perfect world, okay, but it's a new world, thankfully. We look forward to our patients aging. We look forward to recognizing that they're going to get the same problems as everybody else in the course of aging. Hearts stiffen. That compounds pulmonary hypertension. People get arthritis. People slow down a little bit, which is normal, but on top of pH, they may lose more muscle mass from it. People with connective tissue disease may, for the reasons that were mentioned, and also, sometimes it affects muscles too, if it's connective tissue disease. It hasn't been described per se with idiopathic, although there are a lot of muscular abnormalities in metabolism and the fibers that sort of make muscles contract, the contractile apparatus in muscles, that are not normal in PAH, in idiopathic PAH. It's not we don't think it's the idiopathic PAH causing it. It may just be that they have a severe illness and that's affecting the muscle, but no one knows for sure. No one knows for sure. But all those things, and I would say to anybody in this room that lost a bit of muscle mass in the last 3 years, it's perfectly understandable. We've been trapped in our houses, we've been on Zoom, people weren't active. I see this all the time. My patients are constantly telling me that they're vastly deconditioned compared to 2 or 3 years ago, at whatever level of functioning they had before. So it's not surprising that people are feeling more tired. People find their exercise capacity has come down a bit, and it's a struggle to get it to come back up. But that's what everybody's got to be doing. That's what I'm saying all day to people in clinic. Push yourself, push, and hopefully it'll come back.
Thank you. That's great. Michael, this one over here.
Hello, I just wanted to know if someone with scleroderma that has caused pulmonary hypertension has a lesser outcome than somebody idiopathic or other reasons? Does the scleroderma cause it to be worse? I don't know.
Okay, so the short answer on the average is yes, okay? The longer answer, I'm reminded of Stephen Jay Gould, who was one of the world's experts in fossils. He was a professor at Harvard. And at a very young age, he developed a terrible abdominal cancer. And they told him he had 6 months to live. And he lived another 29 years, okay? And so he wrote a wonderful book about athletes and how you don't see 500 hitters, called, okay? I'm not a baseball aficionado. 500 hitters very often, but you see a lot of average hitters. When we show those curves, and everybody sees these curves over years, those curves, in essence, are an average. And they're being driven by people who are doing great, but they're also unfortunately being driven by people who are doing terribly, okay? And it's extremely hard to individualize from a curve. So the best we can say to someone is, on average, someone with scleroderma will not do as well necessarily as someone with another type of PAH. That may not be surprising. Why? Because number one, there's no cure for scleroderma. Scleroderma keeps going. It's like the fire's still on, okay? The other thing is that scleroderma can affect other organs. You know, when you really have pure idiopathic PAH, it doesn't really attack many of your other organs directly, okay? But scleroderma can. And so when you look at those curves, you have to say to yourself, well, is the person really getting sick from PAH, or are they getting sick from all the other stuff that's going on around the scleroderma? And there are studies showing it's a bit of both, okay? And that, of course, the PAH is important. So the short answer is yes. The longer answer also is that all of our therapies pick the curves up regardless of the cause. Now, again, that's a group curve. It can't necessarily refer to an individual. But there's lots of hope, too, for scleroderma patients now. And even our most recent study, the study with sotatercept that was just published, the scleroderma group, it was a small group, but it showed that people with scleroderma seem to get benefit from it, too. And so there's hope in all of our different types of PAH.
Thank you. I have time for one more question.
Hi, my name is Dawn. I'm just wondering, hypothetically, we'll say hypothetically, if someone is discharged from a PH clinic, even though they still have PH, probably, well, mild, but there are other issues. So there were cardiac issues and other underlying lung issues. And at the beginning, trying to figure out which was the cause of the PH, or was it both? And then kind of getting pushed along more to the congenital cardiologist to take over and keep an eye on things. So then getting discharged from the clinic, I've wondered why that would happen. I'm sure there's various reasons, and maybe different reasons for different doctors. But do you know of reasons why that would happen? And at what point would I push to come back to the clinic? Obviously, if you feel like you're deteriorating, but is there any other reason?
So it's hard to talk about a particular case, but we see in a year hundreds of people that we end up referring back to their doctors. We view our job as ensuring, and I'm sure we're all the same, but we view our job as ensuring that the person has received the correct evaluation and diagnosis. And then based on that, there's planning. So if I find that someone has a lot of lung disease, group 3, that's causing the PH, not PAH, PH, they'll go back to their lung doctor. If they have heart disease, heart failure of any sort, left heart disease, they'll go back to their cardiologist or to the heart failure clinic or whoever is going to manage that, because we're sending them back to people who are perfectly capable of managing those problems, okay? For someone with congenital heart disease, the best person, and the person I turn to all the time, are my congenital heart disease colleagues. And it's not unusual for me to say to them, well, first of all, if there's no PH or very little PH, that's consistent with the congenital heart disease, they're managed by the congenital heart disease specialist. We leave our door open, but it's rare that people come back because they are being managed by the right person otherwise. Now, if the pulmonary hypertension were to become extreme, or there was a suggestion of another cause like CTEPH or other causes on top of something, then yes, of course, we would see them again. What are the practices across the country? Because each clinic has their own way of doing things.
In Ottawa, for example, our doctors, and this is how they even train fellows and residents, that if someone is, pulmonary hypertension can be caused by many things, and it's not, most of the time it's not pulmonary arterial hypertension or chronic thromboembolic disease. But if the patient has been referred and there's significant cardiac disease or lung disease, and it's not group 1 pulmonary hypertension, we refer them back to the person who referred the patient to us with suggestions. It's pulmonary hypertension because of this, and then this, therefore, is how best to manage that. And again, like Dr. Langleman said, always with the end sentence that says, if you have any further questions, feel free to reach out or refer the patient again.
In Calgary, we have a combined congenital heart and PH clinic that our Dr. Helmerson runs. So our cardiologists will also order maybe single or dual therapy PAH, but they're primarily managed through the cardiology section of that clinic. So I guess to answer your question though, when is it time for you to ask to come back? I think you can call your PH program nurses and just have a chat with them as well. Same?
Yeah. Thank you so much, everyone, for attending and for your questions. Thank you to my wonderful panel. I really appreciate your time and expertise. If you still have questions, these wonderful folks are here. Maybe corner them along the break and see if they'll answer some more of your questions. We are going into break right now, so we'll be on break for the next half an hour, so 2:15 to 2:30 or 2:45, and we'll be back here at 2:45 for our closing plenary on looking at future research trends. I encourage you to come back for that, and then we'll wrap up for the day. So thank you all so much, and we'll see you again soon.